Mr. Evans, 68-year-old male history. Recent viral illness, 2 weeks ago. Stage 2 lung cancer, diagnosed 4 months ago. Chronic atrial fibrillation on apixaban. Hypertension. Presentation, my chest feels tight and I can't catch my breath when I lie down. Vitals, BP 98/60ths, from baseline 140/80, HR 128, irregular, RR 26, SpO2 92% RA. Physical, jugular venous distension, JVD, muffled heart sounds, clear lungs. ECG, sinus tachycardia, electrical alternans. Electrical alternans in this context is a warning sign of tamponade, particularly when paired with hypotension, jugular venous distension, and muffled heart sounds. Emergent bedside ultrasound and pericardiocentesis are often required.
This is a PHS X-ray of an adult. There are no patient-identifiable data on the X-ray. The patient is slightly rotated to the right. There is a satisfactory inspiratory achievement and adequate penetration. So the most striking abnormality is an enlarged heart with cardiothoracic ratio of over 50%. It also has a globular appearance in keeping with a pericardial effusion. Apart from a minor left basilar atelectasis, the lungs are clear with no consolidation, collapse, and lung masses or nodules. The costophrenic angles are sharp, with no evidence of the pleural effusion, allowing for patient's rotation. The trachea appears central. There is no free subdiaphragmatic gas. No skeletal or soft tissue abnormality are identified. So in summary, this chest X-ray shows a large globular-shaped heart in keeping with pericardial effusion. The differential diagnosis of this is huge. Blood tests including CBC, BUN, electrolytes, thyroid function should be performed. An EKG should be required to assess ischemia or pericarditis. Further investigation and management with cardiology should be consulted. She is symptomatic. She may require a therapeutic pericardiocentesis.
What X-ray finding confirms pericardial effusion? A. Enlarged cardiac silhouette. B. Radio-opaque lines outlining pericardial sac. C. Pulmonary vascular congestion. D. Mediastinal shift. Answer. B. Radio-opaque sac lines differentiate effusion from cardiomegaly. Which assessment finding suggests cardiac tamponade? A. Hypertension. B. Pulsus paradoxus. C. Bilateral crackles. D. Fever. Answer. B. Pulsus paradoxus. Decreased BP over 10 mmHg on inspiration indicates tamponade physiology with increased pericardial pressure. The nurse should immediately prepare for A. Stat echocardiogram. B. Pericardiocentesis tray. C. For antibiotic administration. D. Chest tube insertion. Answer. B. Pericardiocentesis relieves tamponade. Delay risks cardiac arrest. Which medication must be withheld? A. Lisinopril. B. Apixaban, anticoagulant. C. Acetaminophen. D. Furosemide. Answer. B. Apixaban, an anticoagulant, increases bleeding risk during invasive procedures. Positioning priority for this patient. A. Left lateral decubitus. B. High Fowler's with legs flat. C. Trendelenburg. D. Prone position. Answer. B. High Fowler's reduces preload. Legs flat maintains cerebral perfusion. Most critical pre-procedure instruction for pericardiocentesis. A. Hold food for 6 hours. B. Do not cough during needle insertions. C. Practice deep breathing. D. Empty your bladder. Answer. B. Coughing may cause cardiac laceration during needle insertion. Immediate post-pericardiocentesis procedure. The nurse prioritized to monitors for A. Hypertension. B. Ventricular arrhythmias. C. Hypoglycemia. D. Urinary retention. Answer. B. Ventricular arrhythmias indicate myocardial irritation due to needle trauma. Which lab result suggests malignant effusion? A. Elevated CRPB, positive cytology for cancer cells. C. Leukocytosis. D. Low albumin. Answer. B. Malignant cells confirm cancer-related effusion, which will change oncology plan. While other lab results might suggest inflammation or infection, only positive cytology provides a definitive diagnosis of malignancy. Because the cancer is now officially stage 4, metastatic, the intent of treatment changes dramatically. It shifts the goal from cure to control palliation. Positive cytology is the only result that pathologically confirms the cancer has spread to the pleural space, thereby changing the stage, the goal of treatment, and the need for ongoing fluid management. The provider orders IV colchicine. The nurse understands. A. This treats bacterial infection. B. This reduces recurrent inflammatory effusions. C. This dissolves blood clots. D. This prevents atrial fibrillation. Answer. B. Colchicine prevents recurrent inflammatory effusions, which is the first line for pericarditis. The most important discharge teaching after a pericardiocentesis should emphasize A. Restart apixaban today. B. Report pulsus paradoxus immediately. C. Limit fluid intake to 1L/day. D. Sleep flat to improve breathing. Answer. B. Pulsus paradoxus signals recurrence, which needs emergent intervention. When you walk into the room, the patient looks terrible, hypotension. You look at their neck, and the veins are popping out like they're lifting a heavy weight, JVD. You put your stethoscope on their chest, and you can barely hear the heartbeat, muffled sounds. If you see these three together, you don't wait for an ultrasound. You call for a needle to decompress the heart immediately. Mnemonic fatal effusion for tamponade management. Fowler's position anticoagulants hold tamponade signs, Beck's triad, arrhythmia monitoring labs, cytology, CRP, cultures emergency pericardiocentesis, fluid analysis priority fever workup, infection. Upright X-ray key serial echo/ECG instruction on recurrence signs oxygen ready no NSAIDs if hemorrhagic.